Good evening, everybody. Respected President SAMS, Dr. Avinash Bhosle, sir. Then Vice President, Dr. Vikas Karne. Immediate past President, Madam, Dr. Anita Nete, Madam. Then Treasurer, Dr. Sachin Chandorkar. President-elect, Dr. Rajesh Tagadpalli. SAMS Newsletter Editor, Dr. Shilpati Vaskar. Today's invited chairperson, respected Dr. Bala Bhaskar, sir, the past President of ISA National, and Dr. Jason R. Doctor, who is a who is a professor and head at Tata Memorial Center. Then today's invited faculty, Dr. Saurabh Bade, consultant anesthesiologist from Nagpur, Dr. Sandeep Kadam, professor and head Devi Patil Medical College, Kolhapur, and Dr. Amit Shah, sir, who is a legend in airway management, and he is a consultant anesthesiologist from Baroda. Then today's MMC observer, Dr. Tukaram Rathod, he is a past president of IMA State of Maharashtra. Then all past office bearers, all national GCs, all SAMS advisory, all GC members of SAMS, president, secretary of different city branches of SAMS, and my dear delegates, a warm greeting from the SAMS. On behalf of SAMS and ISA Yavatmal and IMA Yavatmal, I welcome you all in the SAMS curriculum, that is a code airway, think, plan and rescue. I would like to thank first Dr. Himlata Badke, President ISA Yavatmal, and Secretary, Honorary Secretary Dr. Archana Parkut for getting the MMC hour for today's webinar. So we will start the webinar from for a prayer. So, taking blessings from Ma Saraswati and the divine light, I would like to invite our President SAMS, Dr. Avinash Bhosle, to deliver his welcome address.
Thank you, Sheetal. Good evening and welcome you all for today's webinar. It is difficult to define difficult airway. One clinician may face difficulty in a situation where other may not, or he will find it easy. The definition is not standardized in any literature. The difficulty of airway management is highly variable and will depend upon several factors, including patient characteristics, medical and surgical history, airway examination, the clinical conditions for which airway management is required, and the patient's current status and vital signs. Algorithm for managing the difficult airway have been outlined by national and international bodies. We should follow the cockpit strategy for airway crisis and algorithm adherence, because what it is we see in the airplane, difficulty in ventilation and or intubation after induction of anesthesia creates a panic scenario in operation theater many times. Anesthesiologists need to take quick decision to prevent crisis, and this. Let us learn and revise our knowledge about airway challenges on this webinar. So I request Dr. Srital to start introduction of the speakers, chairpersons and speaker. Thank you.
Thank you, sir. So taking this opportunity, I would like to request all delegates kindly registered for SAMSCON 2026. It is a biennial CME by Society of Anesthesiologists Maharashtra State Society, and you should block the dates by 2nd, 3rd and 4th October, which is organized by the Organization of Anesthesiologists Satara branch.
It's my personal invitation to all. Huh?
So let's introduce today's MMC observer. He is a physician from Yavatmal, Dr. Tukaram Rathod. He has done fellowship in diabetes at All India Institute of Diabetes at Raheja Institute, Bombay. He is a practicing diabetologist since last 30 years. He has participated and presented papers as academician in Japan, Switzerland and Dubai. He is a director of Chetang Nursing Home, Shivaji Nagar, Yavatmal, director of Irachan Memorial Super Speciality Hospital, Yavatmal, and he is a past president of IMA Maharashtra State. So welcome, sir. Now I request our Vice President Dr. Vikas Karne sir to introduce our today's chairperson.
Thank you, Dr. Sheetal Madam, and good evening to everyone. Airway always remains very close to us as an anesthesiologist and always remains challenging. So this is a very interesting webinar, and we have two masters in the field today as chairpersons. So it's my pleasure to introduce and welcome Dr. Bala Bhaskar sir. Sir is Professor, Department of Anesthesiology and Critical Care at BMCRC at Bellary. Sir is past National President of Indian Society of Anesthesiologists, that is past Editor-in-Chief of Indian Journal of Anesthesia. He is the Deputy Editor, Update in Anesthesia by WFSA. He is an ex-member Publication Committee of WFSA. He is member of RJMS BLDE, which is deemed to be university. He is ex-adjunct professor and faculty of Manipal Academy of Higher Education. He is also ex-member secretary of IEC BMCRC Bellary, and he is chief coordinator for 4 ISA clinical practice guidelines. Sir has over 60 publications and more than 200 lectures and 4 book chapters. And his primary area of interest is research, guidelines, education, and simulation. It's my pleasure to welcome Dr. Jason Doctor, my dear friend. He is MD and fellowship in onco-anesthesia and pain management. He is professor and consultant anesthesiologist at Tata Memorial Hospital, Parel, Mumbai. He is a postgraduate teacher. He is a recipient of Homi Baba National Institute Best Teacher Award in 2025. He has been member of Guidelines Committee for drafting AIDAA Airway Guidelines in 2016 and 2025 with corresponding author for pediatric guidelines. He is editorial board member of Indian Journal of Anesthesia between 2017 to 2026 and Airway Journal 2023 to 2026. He is AIDAA National Vice President 2023 to 2024 and AIDAA National Vice President 25 to 27.
Sir, 1 minute. Ganesh, please share the slide. Some problem with my laptop.
गणेश स्लाइड दिसत नाही
Ganesh.
इंट्रोडक्शन.
Hello, Ganesh.
Ganesh, are you there? Please continue, Dr. Vikas.
No, sir.
Dr. Jason is also executive member of Society of Onco-Anesthesia and Perioperative Care. He has over 50 publications and he has contributed to 15 chapters in various books. His areas of interest remains management of difficult airway, pediatric anesthesiology, and onco-anesthesiology. So it's our honor to have Dr. Bala Bhaskar sir and Dr. Jason Doctor to be present today as chairpersons. So we welcome you, sir, and I hand over to Dr. Sheetal for further proceedings. Thank you.
Hello, Ganesh, please share the slide.
Ganesh,
Ganesh, next slide.
Now I request Dr. Shilpa Tivaskar to kindly introduce our faculty, Dr. Saurabh Berde sir and Dr. Sandeep sir.
Yeah, so we have today difficult airway, and unanticipated difficult airway is always a nightmare. So let us hear from our stalwarts how they guide us through that. And here we have Dr. Saurabh Berde sir. It's a great honor to introduce sir. Sir is a chief consultant anesthesiologist at RNH Hospital, Nagpur. Sir is a visiting faculty at Datta Meghe Medical College, Nagpur. Sir has served ISA Nagpur at various positions as a president, vice president, and Sir is a reviewer of Indian Journal of Anesthesia. Sir is a National Executive Committee member of AORA. Sir was the organizing secretary of first Maharashtra State Biennial CME and faculty at various regional, state, and national conferences. His talks are always encouraging and engaging. And Sir is a faculty and has interest in ultrasound in anesthesia, focus, regional anesthesia, airway, cardiac patient for non-cardiac surgery and perioperative pain management. We welcome you, sir.
Thank you, ma'am.
Ganesh, next slide.
It gives immense pleasure to introduce our second faculty, Dr. Sandeep Kadam, sir. Sir, always his talks are very lucid and very engaging again. Sir is an MD anesthesiologist and has done fellowship in chronic pain and palliation. Sir is Professor HOD Anesthesiology at D.Y. Patil Medical College, Kolhapur. He is faculty at various Maharashtra national conferences, regional and national conferences. Sir is a faculty always at AORA conference and at AOA conference, that is Obstetric Anesthesiologist Conference, and National Airway Conference. Sir has special interest in difficult airway management, simulation, chronic pain management, and has more publications to his account. Thank you. We welcome you, sir.
Thank you, Dr.
Thank you.
Thank you, Dr. Shilpa. Next slide, Ganesh.
Over to you, Dr. Sheetal.
Thank you, Dr. Shilpa. It's my honor and immense pleasure to introduce the legend in the airway. It is Dr. Amit Shah. He is a consultant anesthesiologist from Barodara. He is a president of Barodara City Branch ISA and Association of Practicing Anesthesiologists. He has interest in advanced and difficult airway management, low flow anesthesia also, and he has patented his Patpa variable laryngoscope and also developed a high flow nasal oxygen device. He has chaired the trainee committee of International Airway Management Society. He was General Secretary of All India Difficult Airway Association. He was Post Director for Advanced and Difficult Airway Fellowship at IDA. Then he has delivered oration at National Airway Conference at Srinagar, and he has almost delivered more than 300 lectures in regional, national, and international conferences and conducted more than 100 workshops on airway management and low flow anesthesia. He is a recipient of Academic Excellence Award, Bhopal Award for Academic Excellence in 2017 from ISA National, and he is also recipient twice of ISA President Appreciation Award. He has 39 national and international publication and book chapters, and he is a author and co-author of IDA 2026 guidelines and is associated with papers and airway management guidelines in COVID-19 and co-author of IDA First Indian Difficult Airway Guidelines 2025. So welcome, sir. Ganesh, sharing the top.
So much for the kind introduction. Thank you.
So now I request our first faculty, Dr. Saurabh Berde sir, to deliver his talk.
Okay, thank you. Is my slide visible?
Yes, yes.
Is it full screen?
Yeah.
Yeah.
No, it is not now.
Right, it's visible. Now you are not. Yes.
Is it full screen now?
Yes, yes.
Yes,
yeah.
yes.
So good evening, everyone. Thank you, Team SAMS, for organizing this webinar and giving me this opportunity to speak today. Thank you, both the chairperson, Dr. Balabhaskar sir and Dr. Jason sir. Congratulations to Team Yavatmal ISA for doing wonderful job and getting involved in this webinar also. Most of the practicing and senior analysts are well aware of various methods of airway assessment. This talk should be useful as a revision to them and more useful to the postgraduate students. There is no conflict of interest. Any QR code on the slide is the reference article. of that slide. Because of lot of improvements in patient monitoring, airway devices, clinical protocols, and structured training, the risk associated with unanticipated difficult airway have reduced. But still, the surprises arising out of unanticipated difficult airways remain major concern in clinical practice. These are kind of patients we get. Few are more difficult than these. But how do we define? We define difficult airway when we have either difficult mask ventilation or difficult supraglottic airway ventilation or difficult laryngoscopy or difficult intubation or difficult front of neck abscess. But always remember, hypoxia kills the patient and not the technical absence of advanced airway. So objectives of airway assessment in any patient is to identify patients who may be difficult to ventilate or intubate, identify patients that may require the different airway interventions. We define difficult mask ventilation as inability to maintain adequate oxygenation or ventilation using face mask, and we define difficult SGA ventilation as inability to place the SGA in satisfactory position to allow clinically adequate ventilation and airway patency. We call difficult view at laryngoscopy when we are unable to see any portion of vocal cords with conventional laryngoscopy. When an experienced anesthesiologist uses direct laryngoscope and has more than 2 attempts with same blade or change in blade or an adjunct to a direct laryngoscope, or use an alternative device or technique following failed intubation with direct laryngoscopy, we call it as difficult intubation. So what is the rationale of airway assessment? There is definitely a significant incidence of difficult mask ventilation. Out of up to 6% of cases, out of this up to 2%, 1.5% of patients are impossible to grade mask ventilate. There is significant incidence of difficult intubation as well in elective surgeries, and failed intubation occurs in up to 3 patients in 10,000 of cases. But what is more important is difficult intubation is significantly higher in emergency departments, and failed airway is at least 10 times more in emergency setting versus elective anesthesia. So with airway assessment, we formulate a first step for an appropriate airway plan. We ensure any abnormalities if are any detected, and we ensure an appropriate safe strategy which can be employed, and then so that we can negotiate the potential problems with the maintenance of oxygenation and ventilation during airway management. What needs to be assessed? Any previous history of airway difficulties, cardiorespiratory, this is a significant thing in airway assessment. Likely impact of surgery on the airway, that could be previous surgery or the scheduled surgery. Any chance of difficult bag and mask ventilation, difficulty in placing supraglottic airway, is there any intubation difficulty, is there any difficulty in PONA, is there any risk of aspiration, and obviously problems at extubation, which should also be assessed. Langeron in 2000 gave 5 independent predictors of difficult mask ventilation, which included age more than 55 years, body mass, some obesity, facial hairs, lack of teeth, history of snoring. But Khetrapal changed that to body mass index more than 30 kg per meter square, with inability to protrude the jaw and thick neck and radiation changes in the neck. He added these Khetrapal et al. Added all these factors. So how do we grade mask ventilation? Grade 1 is the easiest thing. Grade 2, we need some airway adjunct or muscle relaxant to ventilate the patient. Grade 3, we need additional help. So we need 2 providers, and grade 4 is inability to ventilate. Murphy has given many mnemonics in the airway, and he has given moans as a difficult bag mask ventilation mnemonic. This include all the factors which I just described. Adequate SGA ventilation is defined as tidal volume greater than 7 ml per kg with leak pressure no greater than 15 to 20 centimeters of water, and the incidence of difficult SGA insertion is less than 1%. But there are chances of SGA failure also, and it is defined as airway related event requiring the removal of SGA and requiring tracheal intubation. This incidence is up to 5% of the difficult SGA insertion. Murphy has given mnemonics as a rods for that: reduced mouth opening, obstruction at any level below the SGA insertion, distorted airway, and stiff neck and lungs. So there are the preoperative airway assessment tests ideally should be simple, quick, cost effective to perform. Should have high sensitivity, high specificity, and high positive predictive value. But traditional tests are subjective. They have low sensitivity, not very high specificity, and they have low positive predictive value. What are these tests? Clinical or bedside test and after laryngoscopy. The clinical tests are mouth opening, traditionally said as 3 fingers should be there. Incisor gap should be more than 5 centimeters. Mallampati grades, there are 4 grades. Jaw protrusion, there are 3 grades of jaw protrusion. Can be protruded beyond upper incisors, up to upper incisors, and cannot be protruded even up to upper incisors. Upper lip bite test, again 3 grades. Lower jaw can bite above the upper lip, at the upper lip, and cannot bite the upper lip. Thyromental distance, the minimum distance should be 6.5 centimeters. Sternomental distance is double the thyromental distance, 13 centimeters. High mental distance, 4 centimeters. There should be adequate cervical spine mobility. And neck circumference. Neck circumference is usually not taken as this criteria in most of the things, but recently they have come up with 42.5 centimeter as the cutoff for which can tell the difficult or easy intubation, and of course the prayer sign, which is seen in diabetic uroarthropathy, most commonly seen with diabetic uroarthropathy, which indicates that there are chances of stiff joints all over the body. Then there are combined tests which take all these individual criteria into consideration. Layman is the mnemonic abbreviation for look, evaluate, Mallampati, obstruction, and neck. There is a 332 rule of in evaluation: 3 fingers mouth opening, 3 fingers thyromental distance, and 2 fingers hyomental distance. Then Wilson risk score, Alganzari risk index, and Ahn risk index. Wilson risk scores takes 5 criteria, which scores from 0 to 2. 0 is easy intubation and 2 is severe condition. But the problem with this is that even the score of 2 is sufficient to call it as difficult intubation, and a single factor can change this or modify this thing. Even jaw movement or interincisor gap less than 5 centimeter is sufficient to tell that only one single factor is significant in this score. Alganzari score, it has 7 criteria. The minimum score should be if less than 8 or more. If it is more than 8, it indicates the difficult intubation. Then Ahn index, this is this has taken there are different scores, and this has taken interincisor gap or mandibular luxation with higher score of 13. So any score, so this has considered the mouth opening as independent and given a higher score, and if any score more than 11 is considered as difficult intubation. So if we consider all of these tests, they have a very low sensitivity, not very high specificity, and low positive predictive value, except Ahn index, which has a fairly good sensitivity, specificity, but still positive predictive value is low. That means they'll definitely tell us easy intubation, but less likely to tell us difficult intubations. So after laryngoscopy, Cormack-Lyon score, modified Cormack-Lyon score, and POGO score, and intubation difficulty score. POGO score is not used nowadays because it is again a subjective thing, how much percentage of glottic opening we have seen. And IDS is a retrospective score. So this is helpful in the next intubation if at all we consider it. These are 3 pictures I had taken: grade 1 Cormack-Lyon, grade 2, and grade 3. Grade 4 I could not picture it because that was an emergency thing for me. Cook has subdivided this grade 2 into A and B, and Benumov has subdivided grade 3 into A and B. So this is now modified Cormack-Lehan classification. After this laryngoscopy, the Murphy has given the mnemonic for FONA, that is short, surgery on neck, hematoma or infection at the neck, obesity, radiation, changes in the neck, and tumor in the area of doing surgical access. So when we discuss airway assessment and anticipate difficult airway, we should be knowing the fundamentals of airway anatomy, laryngoscopy, and intubation. In 1944, in Lancet, this article was published, and it was discussed three axes of there are three axes in the airway: oral axis, pharyngeal axis, and laryngeal axis. With neck flexion, the pharyngeal axis and laryngeal axis, they align, but still oral axis is not aligned. So with the sniffing position, the oral axis comes out towards these two axes to align with the so that all three axes get aligned, and we can have good laryngoscopic view. Houghton Houghton has described this sniffing position as by measuring with gonometer, and he consider supraorbital foramina, infraorbital foramina, and mental foramina in one line, forming a 15-degree angle at and upper border of sternum and cricoid cartilage line joining forms the 35-degree angle with the ground. This gives a perfect sniffing position according to the Houghton et al. But Magill in 1936 is the first person who described the sniffing position, though he did not give the angles. Greenland in 2008 gave two curves theories: primary curve, which gives oropharyngeal, which is the oropharyngeal curve, and secondary curve, which is pharyngoglottic and laryngeal curve. So what he describes that with sniffing position, the primary curve that gets lessened or decreases, and this the line joining between primary curve and secondary curve gives the laryngomestibular axis. So whenever this laryngomestibular axis shifts counterclockwise towards line of sight, that becomes a easy intubation, and vice versa. So with laryngoscopy, all the two curves, they align, and they align with the line of sight, and we get a easy view of glottis. What happens with the retrognathia? This primary curve gets accentuated, and the laryngomestibular axis shifts clockwise away from the line of sight. Same thing happens with the short thyromental distance. The primary curve gets accentuated, and the laryngomestibular axis shifts clockwise away from the line of sight. That's why there are these are the difficult intubation or difficult to view cases. The RAM position, when in RAM position, when we give RAM position obese patient, again the same thing happens. Laryngomestibular axis shifts toward anti-clockwise towards primary curve, and we get a very good laryngeal view. Greenland in 2010 gave a 3-column model for direct laryngoscopy. He called them as anterior column, middle column, and posterior column. Middle column is the same airway passage with primary and secondary curve. Posterior column is the vertebral column, and the anterior column is the pyramidal shaped space, which is bound by two condyles of the mandible, posteriorly, anteriorly by lower incisors, and inferiorly by hyoid cartilage. So anything which causes alteration in these distances will cause the difficult intubation. Like if this TMJ distance is less, then that will be a higher palate, and that will cause a lesser volume, upper airway volume in this space. If this lower incisor, they shift backwards, this space is decreased, and that will cause in case of retrognathia, that will cause difficulty airway. So evaluation of the anterior column consists of volume of submandibular space, that could be relative or absolute. When there is retrognathia, that is absolute reduction in the submandibular space, and where is protruding upper incisors, which come beyond the lower inside, that is called as relative change in the volume of submandibular space. Then compliance of the submandibular tissues because of anything, stiffness, large tongue mass, whatever causes that changes the volume of this space, range of movement of temporomandibular joint and range of movement of styloid ligament. All these factors affect the anterior column. Now, there are other methods of airway assessment also: ultrasound, nasal endoscopy, CT scan, MRI, virtual endoscopy. Nasal endoscopy usually used by ENT surgeons in the OPD practice. We can use them before the induction to know to confirm the or to assess the airway. Then CT scan and MRI take a longer time. They are not easy to do. And virtual, when we these when we film virtual endoscopy is done with the formation of with the use of CT scan and MRI only. We need different films, and we form a virtual endoscopy video of the airway. So airway ultrasound usually done with linear and curvilinear probes. It helps in assessment of airway size, prediction of difficulty, choosing endotracheal tube in pediatric patients. We can confirm endotracheal tube and LMA placement or SGA placement and depth. It can help in ultrasound guided invasive procedures like surgical access. It helps in prediction of post-extubation stridor. It helps in detecting upper airway pathologies in preoperative period. It helps in superior laryngeal nerve block when we are doing awake intubation. And of course, it helps in nil by mouth state by knowing gastric ultrasound. There are 5 views from below upward: suprasternal, cricothyroid, thyroid, thyroid, and suprahyoid. Mainly thyroid and suprahyoid views help us in knowing these are the fastest way to know the difficult airway or the condition of the airway or airway assessment when we do it. This cricothyroid view helps in knowing where is the cricothyroid membrane. This is cricoid cartilage, thyroid cartilage, and in between we find the cricothyroid membrane. This is we find it by doing sagittal scan at the level of the cricothyroid membrane. And we can also make out a string of pulse of tracheal rings where we can actually make mark these things to know to do the percutaneous tracheostomy when in emergency. Then this is at the thyroid level. We see a baby face sign. The eyes of baby face is formed by thyroid muscles, and the mouth is formed by the epiglottis, base of epiglottis. The space in front of the epiglottis is the pre-epiglottis space where our tip of laryngoscope lies when we do laryngoscopy. So if this pre-epiglottic space and the distance from skin to epiglottis, if both these distances are directly proportional to the Cormack-Lehmann grading. So higher the distance, more difficult will be the Cormack-Lehmann grading. Then when we use curved probe in the horizontal plane at suprahyoid level, we can measure the tongue thickness. If tongue thickness more than 6.1 centimeter, that definitely indicates difficult airway. If we find a black shadow beyond the tongue, this is hard palate, and if we see a hypoechoic black shadow at this level, that indicates that this patient can be mask ventilation. If absence of this shadow indicates that the mask ventilation will be difficult, and we will definitely need some airway attempts to ventilate the patient. When we use sagittal curved probe in the sagittal plane with marker facing cephalic, this anechoic shadow is a mentum, and this another anechoic shadow is a hyoid. So we can measure the distance, hyomental distance in neutral position, hyomental distance in extended position, and hyomental distance in sniffing position, and we can calculate the ratios. And HMDR2 is a high mental distance ratio 2, that means neutral versus sniffing position. HMDR1 is high mental distance ratio between neutral and hyperextended position. So this difficult airway elation is sonography. This is a protocol where distance between skin to epiglottis is more than 2.54 centimeter, high mental distance less than 5.29 centimeter, tongue thickness more than 6.1 centimeter, or these ratios somewhere around more than 1.1, close to 1.1. Any of one of the factor indicates that it's a difficult airway. So this is an objective way of assessing the airway. Then we can do confirmation of endotracheal intubation by a direct method with air mucosal interface and comet tail sign, double track sign, indirectly by lung sliding sign and diaphragm movement sign. Dr. Madhuri Kodi, the present editor of IJ, has assessed the airway in the pregnancy, and she concluded that skin to epiglottis distance and tongue volume increase progressively through the trimesters, reflecting the changes in the Mallampati scores and neck circumference. So this is always useful. CT scan, they have showed that statistically significant correlation is between modified Mallampati 3 and 4 with a lowered upper airway volume when we measure with CT scan. Something about physiological difficult airway. Physiological difficult airway is the one in which physiologic derailment places the patient at high risk of cardiovascular collapse with intubation and positive pressure ventilation. This is mainly seen with critical ill patients in the ICU setups. Again, the critical areas are the places where the already intubation is difficult, and if we have physiological difficult airway, that adds to further our problems. So baseline physiologic risk is exaggerated when intubation requires more than attempt. Hypoxemia, hypotension, severe metabolic acidosis, and right ventricular failure are the factors which are considered as physiologically difficult airway factors. So they have proposed that awake spontaneously breathing intubation should be done in the physiologically difficult airway. Mosier et al. In 2015 first time described these things, and they have given all these things which during the management of physiological airway. So the modern medical paradigm is oxygenation first. So and the golden rule is never sacrifice oxygenation for the sake of intubation. Thank you.
Thank you, Dr. Saurabh, sir. Now I request both the chairperson to kindly read the remarks. Hello.
Yeah, Dr. Saurabh, very lucid and excellent presentation. You covered most of the practically everything, but I'm sure there are some things that which cannot be covered in a time constraint of 20.
Yes, 20 minutes. Yes,
because it's hard to to some very well summarized, but so you have all these single parameter tests, multiple parameter tests, and increase in the radiological evaluation. So just to give you a heads up that now with the availability of artificial intelligence and there is the virtual endoscopy that you touched on, there are certain softwares that are available that actually collate all these images of CT scan. So when you speak to the person who is handling your packs or at the hospital, they can actually integrate all these images and they can take you through a virtual. So in cases where you are worried about a big thyroid mass and you want to check what is the distal level of airway obstruction, so those will all be anticipated difficult airways. You can actually reconstruct the entire airway image and you can see what the problem is and whether how you will be able to solve it. And with virtual reality, you can actually navigate through these. So I'm not sure how many of you all are aware, but there is a ORSIM based software that is available for bronchoscopy. So as you go on advancing, it's a video game. So you have a fiber optic scope and you go on advancing, and with increasing levels of difficulty, you can actually master more and more levels of difficulty with the fiber optic. So similarly on thoracoscopy, there is a website, Thoracic Anesthesia. You can do a virtual bronchoscopy and see the airway images. So what I'm trying to tell you is as you integrate more and more of software-based and artificial intelligence-based things, very often, I mean, days are not far where you can just take a picture or upload a picture of the patient and it'll tell you with all these parameters whether what is the likelihood of having a difficult airway and what should be your airway strategy and what should be your backup airway management plan be. right? So these are some of the things that are advancing by the day, and I'm sure most of you must have seen the video of intubation being performed by a robotic arm which is circulating on the WhatsApp.
WhatsApp.
So that is really scary, that what are we going to deal with in another 10 years, 15 years to come, maybe even earlier for all that.
Thank you,
Balavaskar,
sir.
sir.
Yeah. So to next team, we have got so much of advances, but in terms of the morbidities and sometimes very unusual, I mean, unfortunately, the mortalities still persist. So despite so many assessment tools, including ultrasound, SSA, virtual endoscopy, and availability of AI. So what I still feel it, we have to never forget about the basics. Just to recollect that we lost Dr. Malampati, but
Yes, in February.
yeah, so it's important to remember about his demise. And still, it's one of the best assessment tools for all of us, especially when you speak about a different, I mean, based upon his original classification was only about 3 gradings, right? That JSL, which predicted about difficult laryngoscopy. You ask the patient to open the mouth, sit at level with the patient, then say yes. At least it gives us a comfort. Yes, I can go ahead. The step 1. So then step 2, step 3 would always follow. So we have to stick to some of the basics here also. And what I would always stress is, of course, Dr. Saurabh did speak about the physiologically difficult airway, which we are discussing frequently nowadays. Most important is the history taking and the global evaluation. So we tend to focus only on the airway. So global evaluation per se, I don't know how we can put it. For example, you have got airway specialists here, Dr. Jason and Dr. Amit. So sometimes we have a gut feeling that this gentleman is going to give trouble to us. So he may have the best of mouth opening. So it gives us comfort that I can put a supraglottic airway. So, but still, we have the thyromental distance is still a good predictor. And of course, ULBT will also add to some assessment about even intubation apart from the laryngoscopy aspect. So, all in all, it's a balance between anticipating with the basic assessment tools, and whenever we have doubts, as you say, we can have the additional thing. And no question about compromising on a patient's oxygenation. So, all are actually highlighted in our recent IDA guidelines. So, and well covered, Dr. Saurabh. Congratulations.
Thank you, sir. I have that virtual fiber optic bronchoscope app in my mobile phone.
Okay. So,
Thank you, sir.
With the
Now we will proceed.
We'll proceed with next picture.
More availability of hyperangulated beds on video laryngoscopy and apneic oxygenation techniques. So where you would have a Cormac-Lehane 4 kind of a thing, if you have an angulated blade, that is, I would say, a thing of the past. That you still have 2B or 3A and you can still pass bougies with an hyperangulated blade of a video laryngoscope, provided you are trained in using the video laryngoscope on a routine basis.
Yes.
So days are not far where people like how we were always taught that you topicalize the airway and you do a conventional direct laryngoscopy and a quick look laryngoscopy. Like that, awake video laryngoscopy is gaining more and more popularity. So you topicalize the airway and secure the airway in an awake kind of. So if you are dealing with an obese patient or a bull neck or something like that, you could just do an awake video laryngoscopy with topicalization, like how an ENT guy would do a nasoendoscopy kind of a thing, and that will change the way we function and manage the airway.
Thank you, sir. Now we will proceed with the second lecture. So I request Dr. Sandeep Kadam, sir, to kindly proceed for it.
Are my slides visible?
Yes, sir.
Yes, sir.
Am I audible? Okay.
Yeah.
So first of all, I would like to thank the organizers for giving me this opportunity to be part of this prestigious SAM's Zoom meeting over here. And I, especially my friend Avinash, for bringing me on the same table with stalwarts like Barde sir and of course I call themselves my gurus, Amit Shah and Apesh Patwa. Patwa is not there today, but with Amit Shah. So let's begin. So, as the theme of the today's lecture goes, is think, plan, and rescue. Let's see where my this lecture fits into. You, as all of you will agree that endotracheal intubation is one of the basic skills we anesthesiologists are masters at, right? And for years together, we have been using these kind of tools, Macintosh blade, Miller's blade, and when in difficulty, coming up with this Trupti blade or the flexible tip, bujies, and of course, various stylets. But video laryngoscopy is undoubtedly one of the major advances in the practical anesthesia in recent years. So a $1 million question, is video laryngoscopy going to replace our conventional direct laryngoscopy? Well, American Society of Anesthesiologists, ASA, way back in 2013 came up with a suggestion that video laryngoscopy should be used as the first choice in airway management in its algorithms of airway management. Same guidelines were stated by DAS guidelines in 2015. What about our own guidelines? Well, our recent guidelines of IDA 2025, it suggests first attempt should be your best attempt. It is recognized that a suboptimal attempt at laryngoscopy is, of course, a wasted attempt. And therefore, it is essential to emphasize that importance of first pass intubation success with use of tools and strategies to achieve this. And video laryngoscope may be the part of that. If you see the summary of recommendations and best practice statements of IDA 2025 guidelines, the question was asked, does video laryngoscopy improve the success rate of intubation compared to direct laryngoscopy? And the answer is yes, video laryngoscopy improves the success rate of intubation compared to the direct laryngoscopy and is recommended to be used as a primary device or in rescue situations whenever expertise is available. And these are the few of the publications stating the same thing. Well, this may be a few repetition of few of the slides, but they are in the context with video laryngoscopy. For years, when we were students, we have learned that 3-axis alignment with sniffing position, etc. And once everything is aligned by sniffing position, we get a linear view from here, so that tracheal axis geometry is linear and we can intubate. Okay. A second theory was put forth by this gentleman, Dr. Greenland. He came up with the theory that the upper airway is a serpentine in shape, wherein the primary curve formed by the oropharyngeal part and the secondary curve depicted in the orange color is formed by the pharynx glottic tracheal curve. And these two curves meet at the inflection point just above the glottis. And he suggested that if we try to straighten these two curves by sniffing position, we can actually, if we try to flatten these curves with the sniffing position, the line of sight from here, we can see the glottis easily and we can intubate by putting the laryngoscopic blade over here and trying to push this part, tongue and its submental part into the anteriorly and push this part in the submental area. And then the alignment occur and we can intubate. Okay, same can be achieved with the ramped position, which flattens both these curves. But what will happen if we cannot achieve this flattening of these two curves? Means if we cannot flatten the curves, it's failure of visualization and as of course it's failure of intubation. Okay, so how to overcome this problem? So if we push an eyesight from here to here, beyond the primary curve, what will happen? Glottic visualization is better. There's no need of aligning the 3 axes. There's no need to give sniffing position. And there's no need to tissue compression. So with the camera fitted over here on the video laryngoscope, we can actually directly see the glottic opening. And we can, so visualization is very much nicer than the routine whatever we would do. So in 2001, John Pesce introduced the first video laryngoscope called as glide scope. And then now in market, we have n number of scopes such as Magrath, the Macintosh with a Macintosh blade, CMAC with Macintosh blade, and a hyperangulated blade with an extra curve for the anterior larynx. That's the D blade or the C blade, which is called as. Then there are Miller's blades. Then there is AirTrack, that's the J-shaped blade with a channel for the tube itself, similarly the King Vision, etc. So there are now in the market, there are n number of video laryngoscopes. This can be roughly typed into two types. One is anatomical curved blade and other is non-anatomical. So let's see what is anatomical curved blade. So if the curvature of the blade fits into this primary curve, it is called as anatomical curved blade. So examples are the J-shaped King Vision or C&E, that is hyperangulated blade from CMAC. And non-anatomical blade is conventional Macintosh blade wherein the camera is fitted 2 to 3 centimeters just proximal to the tip. So it is similar to the blade what we use for a conventional laryngoscopy. So in non-anatomical blade, what can we do? So we have to have snipping position in this patient. The learning curve, of course, is very less. I'll tell you, learning curve of video laryngoscope, all of us using the video laryngoscope for the first time do have difficulties, and there is definitely a learning curve for each video laryngoscope. So as compared to the D blade, the learning curve for this Macintosh blade is much less because we are used to the Macintosh blade. Okay, so we can overcome all the intubations in almost 90 to 95% of the patients, and traditional sniffing position can be used. And if difficulty arrives, we can use bougie and stellate, especially with Macintosh blade. Now coming to the anatomical curved or J-shaped blade. J-shaped blade, so you can see this curvature of the J-shaped in King Vision fitting exactly into the primary curve over here. And so we have overcome the difficulties of primary curve, and the camera is fitted at this tip, and we can visualize this glottic opening directly. And this being at the proximal end, we can have a panoramic view. So part of pharynx as well as glottis is visible nicely, similar to this picture over here. And this is a CMAC or CMAC D blade, wherein it is a bit elongated, slightly more curved, and as compared to the J blade, the tip fits much further, and we don't get a panoramic view, but we get a nice glottic view like this. So every blade has its own indications and contraindications. So if we see that evolution of intubation, visualization, assess co-evolution with DL in the era before 2002, before video laryngoscopy, with our direct laryngoscopy, the most important failure which occurred was because of failure of visualization. If we couldn't visualize the larynx, it was difficult to intubate. And with Cormack-Lehman grade 2 and 3, we could overcome partly with help of the bougie or stellate. So let's see what happened after evolution of VL. So now the primary curve, the problems related to the primary curve are gone, and still we have tracheal access gap. So we can visualize that the cords or the glottic opening nicely, but putting the tube into the cords becomes a difficulty with video VLs. All will agree with this. So what are the advantages of video laryngoscope? Well, we can get this vision only with the video laryngoscope, not with the usual direct laryngoscopy which we do with Macintosh blade. Then if in fact with use of D blades, we don't require the sniffing position. In fact, we shouldn't giving sniffing position. There's no requirement of excess force as we use in direct laryngoscopy to lift everything. And these things are important, especially in a trauma patient which requires cervical immobilization. Okay, so as I'm a teacher, I'll tell the advantage of video laryngoscope while teaching my students. So definitely when a student is doing video laryngoscopy, I can guide the patient. I can guide as a trainer can guide the trainee that your blade is going too much in. This is the way you should do. You should see how the larynx appears, how to put the tube, etc. So it simply changes airway management from I to V with VL, right? So these are the few pictures wherein teachers are teaching the students. And this is the small video of that same thing, wherein we can see that the teacher, we can guide the student immediately, see, bahar aa jao, look at the VL properly, look at the glottic opening properly, and then put in the tube, etc. So that is the great advantage. Thirdly, there are non-technical or human factors advantages associated with video laryngoscopy. The whole team can see the view of the larynx, improving the teamwork and communication. For example, putting the burp. So you can see this is I have done in my simulation lab on the mannequin, wherein I can see the view. I've asked my assistant to use burp. Now she's pushing the So now she knows exactly how much pressure she should be giving and when everything larynx is visible properly. So these are the few of the advantages of video laryngoscope. Now coming to the actual second part, the troubleshooting in VL. Now, when actually there are 4 steps while doing video laryngoscopy, we explain that these 4 steps are: first is look into the mouth, introduce your laryngoscope. Once you introduce the laryngoscope beyond the base of the tongue, look at the screen. Then you pick up the endotracheal tube, again look into the mouth, introduce the tube inside, and then look at the screen. So we have to follow 4 steps: in, out, in, out. Okay. So these steps are actually meant for avoiding injuries inside the oral cavity. So first troubleshooting comes right from the holding the video laryngoscope. So this is a D blade over here, and introduction of a hyperangulated D blade into the mouth becomes very problematic. So I feel instead of holding the handle, if you hold at the proximal end of the blade itself, introduction of the blade inside the mouth becomes much easier. The problem which most of us face is we can see the larynx nicely, but 76% tracheal access problems. This was noted in British Journal of Anesthesia way back. So I can see the cords, but I cannot deliver the tube is the main problem. So how can we overcome that? So does the use of bougie or stillet improve the intubation success following failed first attempt intubation? And the answer is yes, the bougie helps, especially only with the Macintosh blade. Remember that Macintosh blade, bougie can be used, but bougie cannot be used in a hyperangulated blade, wherein we have to use stillet, stillet, and stillet. So this is the video of trying bougie with a hyperangulated blade. We cannot. So use of stillet and not bougie with VL, especially with J or D blades. So the shape of the tube, what we have to give is according to the shape of the hyperangulated blade itself, or J shaped. So 60 to 90 degrees bend at the left, just proximal end of this cuff we can give. And then once you introduce the tube inside the larynx, we need to pull out the stillet 2 to 3 centimeters and push the tube inside. And while pulling the stillet also, we need to pull towards the abdomen. So another troubleshoot is introduction of tube inside the mouth when the video laryngoscope is inside the head. So to overcome that, many a times, especially with J blades and D blades, it's been observed that we cannot put the endotracheal tube when the laryngoscope blade is inside the mouth. So to overcome that, we can do is insert the scope and endotracheal tube simultaneously, or insert the tube earlier and then the scope. Okay, then other technique what we can be using is, of course, we are going to use stylet, and then insert the ET tube from the right corner of the mouth obliquely and then turn the proximal tip to the front. So this is the way how hold the tube proximally, and then let's see the video, and then introduce on the right angle of the mouth and then turn, of course, then turn the tube. Okay, and the removal of the stylet should be towards the abdomen. It should not be pulled towards the sky. It should be pulled towards the abdomen. So this is a live case over here. So putting the tube, looking at the screen, and then introducing the tube inside the glottic opening. Just enter, wait, ask the assistant to pull, and then push the tube. Aim for 50% of POGO, percentage of glottic opening. The reason behind it is if you aim for 100%, if the glottis is visible 100%, you cannot visualize the incoming tube and it becomes difficult to intubate the patient. So try to see that the larynx from the distance or from the lower part of the glottis so that it occupies the upper half of the monitor. And to achieve that, we need to tilt the scope towards the chest or withdraw the blade slightly. So this should be the aim of our glottic opening. So it should be it should occupy the upper half of the screen, or only partly posterior aspect should be visible. It shouldn't be this way. So if it is, then only it is possible for see that the tube is coming and intubating, actually intubation. Okay. So now when you take the TTT in the pharynx and glottic opening appears anteriorly and ETT tip goes posteriorly, the only thing what we can do is just lift the tube. Please watch this video. So if the tip is going posteriorly, there's no need to leverage on the upper teeth. It is just lifting the tube, aligning it, and then pushing the tube. Okay, there are n number of areas wherein ATTU tube can get impinged. First, I spoke about the oral cavity we cannot put in the intratracheal tube. Now, this is the other way around wherein it gets stuck up at the anterior. So, we have intubated the patient with a stellate and it is getting impinged at the anterior wall of the stellate. So, what we need to do is just withdraw the stellate 2 to 3 centimeters and then only advance the tube and then turn the ETT clockwise. The reason being, in a supine patient, actually the trachea goes posteriorly and towards the right, or other way around, we can flex the head and then we can proceed with further pushing the tube inside the trachea. Then if we are using a Macintosh blade and using a bougie, then the problem what we can arise is this. So you have put in the bougie, the tubing is getting appended against the right arytenoids. Turn the tube on the left side anti-clockwise and then push. So sometimes ETT you have intubated, especially it occurs with the flexometallic tubes, wherein you have put in the tube, it just crossed the glottis and you have removed the stellate and it doesn't tend to go in. So what we do here is put the bougie through it then later on and then push the tube. So if you are using VL for nasal intubation, so you have put in the tube from the nasal cavity, nose and into the pharynx, and now you are finding that the tube is going posteriorly into the esophagus. What to do? So here what I am suggesting is inflate the cuff so that the tip comes anteriorly and then deflate and then push the tube. Okay, so VL can be also be used as VAFI, that is video assisted fiber optic intubation, combination of fiber optic plus VL, wherein this guy is putting the VL through the nose and looking at he has entered the trachea over here. And actually, you know that intubation via fiber optic intubation is a blind intubation. We actually cannot see the tube actually going from the glottic opening, and it can get impinged as I have shown earlier. So this person doing a video laryngoscopy simultaneously, we can actually see the tube going in the glottis. So the key points are visualization easier and superior to DL. All will agree. Okay. Then stylates should be used. An inflection point of secondary curve is solved with force on the tissues. So clinical pearls are experience with Macintosh laryngoscope as usual, or what we are using for years together does not equate to the skill of a video laryngoscope. So every video laryngoscope has its own learning curve. Channel blades, they have, even if the view of larynx, we have to have an optimal view of larynx to push the tube. So while selecting a video laryngoscope, if the selection should be accordingly to few of these points which I'll be putting forth. If the video laryngoscope is being chosen to use as a rescue device when intubation with direct laryngoscopy is unsuccessful, it would be advisable to choose a video laryngoscope with extra D blade or a J blade. And if you are using video laryngoscope as a learning tool initially or a training tool, you should be going first with Macintosh blade. And of course, when you are having blood or secretions in the airway, it is the Macintosh blade which will be helpful because you can see directly. It can be used as a direct light source only, not as a video laryngoscope then. So in conclusion, anesthesiologists have been pioneers in terms of patient safety. Why not be pioneers again? So video laryngoscopes should replace direct laryngoscopes as smartphones have replaced standard cell phones. They should be used for all intubations and the intubation should be recorded and added to the patient digital records. Thank you.
Thank you, sir.
Thank
Very
you.
good
Thank you very
teaching
much.
and very good use of your simulation lab for your teaching. So
Yeah, we
now I
have a
would
good simulation lab in our college, so we can be using that and as a teaching tool for our students as well.
so now I request both the chairperson to kindly put their valuable input.
So, congratulations, Dr. Sandeep.
Thank you, sir.
First points was most important in the sense you said it's all of us agree it's a very good teaching tool. It's not like you said I don't manage. We manage the airway together with our colleagues basically. So that's an important advantage. And when you say yes, axis alignment becomes less important when we go forward. Yeah. So these are some advantages. But one thing which you just said about the documentation per se. So whenever we have a difficult airway, we do encounter unanticipated difficult airway if you got a VL scopy. So we have the recording of the images.
Yeah.
At least seem something like CMAC, we provides us all the details with data cards. Storage device is available. So we can have the devices with the videos with us. We can have images with us. Number one, if we indeed land into some sort of problem, so we can have a debriefing at the end of hopefully a successful intubation. Then we can discuss, and it can in fact have importance in the current day, medical legal
Yeah.
use. So
Yes,
this
sir.
documentation is very good now with respect to where recording facilities are available. Even if they are not available, we have got our own smartphones nowadays. So we can have a look on the monitor and we can store the difficult, not just for teaching. What I am trying to convey is not just for the sake
So
of
record keeping.
record keeping, and it
Yeah.
becomes important document also. So that's one of the advantages. And we speak about alignment being better, and we are able to see almost with a good magnification and going inside. And the trauma comes down. And I also relate the trauma not just to the physical trauma with respect to the hypodermic responses. Yeah. So we simultaneously can look at the monitor, look at the heart rate, and look at the blood pressure, and it can guide us. Yes, there is too much of trauma. A lesser trauma is allowed by VL scopy, and therefore it's good for patients with IHT, hypertension, and other things. So these are an additional perks when we speak about not just intubation, beyond intubation also.
Yes, sir.
A
I
very
agree
good
with you.
message. And again, a small factor is economic considerations for practitioners. I think you didn't touch about economic considerations.
I myself have devised one video lanscope. I'll be coming soon. I've asked
Oh,
for patent for that, and it will be economic,
will
very
be economic.
economical.
Okay, so we'll wait for that.
Yeah.
Thank you.
As Dr. Jason has mentioned earlier, this can be used. We are using the people who don't have fiber optic into devices, bronchoscopes. We can use this for awake intubations after giving upper airway blocks and all. So it is a good tool as well for awake intubation as well.
Sir, I am doing that.
Yeah, we are doing routinely.
Yeah.
So it's a really wonderful talk and very good take-home message and tips. Just to reiterate, for the people who are trainees and who are not very proficient with video laryngoscopy use, so just to reinforce that it has been one of the mainstays for basically it has revolutionized laryngoscopy and airway management in the past 10-15 years. So ever since I remember we used to do a difficult airway course, and the first airway course that we did in 2010, 2010 at Tata Memorial Hospital, we have we were floored by the entire array of equipment that was available within a span of 1 or 2 years. And after that, it's only been on the upward trend. Now we have more than 50 or 60 different types of video laryngoscopes that are available. So I urge all the practitioners to invest in at least 1 or 2 of these video laryngoscopes and do video laryngoscopy on a routine basis in normal airways to get used to that. So don't try and keep it in a cupboard and locked for an emergency use only. Do and use it on a routine basis with different blades, Macintosh, hyperangulated, and channeled. So when you use all 3 different blades, maybe it may be of the same company or a different company, based on how much you would want to spend, what is the budget, where do you work. If you can convince your management to procure it and keep it in the hospital, that is amazing. Or you can have a carry kind of a thing, or a King Vision or Ambu scope, or whichever else different. There are multiple scopes 2RN has come up with. Karl Stoss has, our own Patwa Shahi is stuck in I think marketing this thing, and I'm eagerly waiting your video laryngoscope as well. So but one message, that whichever video laryngoscope you use, please make sure that you use it on a routine basis and not keep it reserved for emergency. Otherwise, you'll be left struggling the way you are struggling with the conventional laryngoscopy, and the advantage is lost, because the learning curve for a direct laryngoscopy and video laryngoscopy are completely different. Here you can see the vocal cords with your eye from outside the oral cavity, and there you are looking at a screen. So your hand-eye coordination needs a certain level of training before you become proficient in the use. So the cuff inflation technique, the hyperangulation, the stillet, moving out the video laryngoscope slightly, to look at the 4 steps, mouth monitor, beginning from the center and keeping enough space on the right hand side for maneuvering your tube and rotating your tube. So all these things you will learn on the go. The more you use it, the better you get. So that's the only thing that I can emphasize. Otherwise, everything else is brilliantly covered.
So, sir, as a private practitioner, we can't afford so many types of blades and laryngoscope, video laryngoscope. So there are so many companies are there, and what you Sandeep said is D blade. So which company's laryngoscope is at present is better?
Sir, I would say any company, any laryngoscope is good.
No,
If you have it, if you don't have it, nothing is there is no use.
So
I have all four blades with me.
not for blades.
Company you want. So I
And
cannot
so,
mention the company as such from here. I
yeah,
don't have actually, but we are
that
using CMAC as well as now recently we have purchased HugeMate. There is Chinese. There are n number of companies coming. So Macintosh blade is required for in 90 to 94%, 95% of patients. We can do a regular scopy with Macintosh blade. Only in 5 to 10% we require D blade. But
but
if you
that's
go on with the D blade from the word go,
yes,
it will be the best. So first attempt
yes,
will be your best attempt.
I've
yes.
seen the practitioner who have their laryngoscope when they started their practice uh,
Yeah.
years back. Even now, the bulbs are not available. They find out from anywhere. I don't know, but they keep on going with that blade only. So
Although
I asked which
SAMS want
company,
to
which is worth as price.
Yeah, sir.
We have to have all shape blades with us.
Yeah.
We
So
cannot
Can I
use.
talk?
basically, what
Yeah.
yeah.
Yeah, so why not BPL, sir?
BPL,
We use,
yes,
BPL
I
gives like,
think same.
Clarity of so VL what you saw was the clarity with
Mm.
HugeMate. You saw
Listen,
my presentations.
I think we should
And
not discuss
yeah, we
companies
should not
here.
discuss the
But
company here. Yeah.
any,
but
any.
what I suggest is that there should be two things which you should look for. One is that when you start, you should have a Macintosh blade so that you can easily get into this. But for difficult airway, you need hyperangulated blade. So rather than looking for company, what you should look for is whether that video laryngoscope has provision for hyperangulated blade as well as a Macintosh blade. Okay. So there are many companies and probably more companies will come in future. What you should look for is a hyperangulated blade as well as a Macintosh blade. Hyperangulated blade will help you in the situations of difficulty. Routine use, blood in the airway, Macintosh blade will work. You should be proficient with both. You should try to use hyperangulated blade because there the view is good, but the intubation, the tube passage is difficult. So you need more practice with that. So you should look for the device which has a hyperangulated blade and Macintosh blade. Okay. That's summarized like everything where what type of video laryngoscope. There are many companies and many more companies will come. You should try to find out whether they have a hyperangulated blade or not and whether they have a Macintosh blade or not.
So
Okay,
just
thank you very much. We'll go to our third lecture. Now it's time is 8:10. Okay. Please, Sheetal.
So now I request Dr. Amit Shah sir to kindly proceed for it.
Okay. Thank you, chairpersons. Thank you, Society of Anesthesiologists for Maharashtra, for giving me this opportunity to speak about our guideline. Dr. Jason is also here with me. So, what I'm going to speak is navigating unanticipated difficult airway, a deep dive into our IDA 2025 guideline. And what I'm going to speak mainly would be on the adult guideline. Is my slides visible and I'm audible?
Yes,
sir.
sir. Yes, sir.
Yes.
Okay,
Please
fine.
go.
So let me take you through, a very simple case scenario. I'm not going in detail of that. I'm just giving you a start. A young female for TLH, which requires you decided for the intubation, mouth opening is okay, malam patti is 3, everything else is normal. You tried routine intubation, video direct laryngoscopy, a first Cormack-Liane grade 3 and first attempt failed. That's a very, very common scenario. Okay. First time you're not able to intubate for whatsoever reason. And from this point is where our guideline starts. Okay. So that's the algorithm for adult unanticipated difficult airway. In 2025, we have published a guideline for adult, pediatric, obstetric, and also for the at-risk extubation. So these are the 4 guidelines which we have published, and you must go through each guideline, not only algorithm, also the main text. This time, our methodology is quite robust. We made a steering committee, subcommittee for each guideline, and then in each guideline, there were research questions were made. They were systematically reviewed. For the first time in probably in any guideline, we have given a classification on the basis of AHA classification to grade the evidence. So whatever evidence I'm going to tell, whatever suggestions IDA has made is graded also with the AHA classification. And in some of the situations where evidence is absent or weak, we took expert consensus, the Delphi survey, which is the method right now to suggest any particular point in the guideline. So that's our algorithm. And first and most important part is a disclaimer. It's a big disclaimer, but there are 3 important points which I would like to highlight. One, this does not represent minimum standard of practice, nor there substitutes a good clinical judgment. So you cannot say कि AIDA ने ऐसा बोला है तो बस ऐसा ही करना है. It depends upon your clinical judgment. You can deviate depending upon your clinical situation. Now, recommendations about specific resources like devices, video laryngoscopy, medications, workforce, apply when these resources are available. Okay. We suggest that video laryngoscopy is a better choice when in a rescue situation. But if you do not have video laryngoscopy, obviously, this would not apply. So in that situation, our recommendation should be used as aspirational. That means if you do not have video laryngoscope, you should aspire to get a video laryngoscope. Guideline also assume that airway operator has adequate experience. That means when we suggest that you do intubation through supraglottic airway with the help of entry intubation catheter and flexible bronchoscopy, you have that equipment and you have that adequate experience to use that. In absence of that, you should use what you are familiar, what you are comfortable, and what you know. Now, this algorithm chart, okay, does not cover all aspect of airway management which we are suggesting. For that, you need to read the text. So our guideline should be read in conjunction with the text. Only reading this part will not be sufficient. And I'll take you quickly through the various important points which we have suggested. So we have suggested about patient preparation, pre-oxygenation, how to optimize tracheal intubation, ventilation, supraglottic airway, and so on. We'll quickly go through that before deep dive into the algorithm part. So for the patient preparation, we have clearly identified that you should do proper airway assessment. Identify if patient is at risk of airway, pulmonary aspiration. We also suggested that you can use ultrasound to find out whether your patient has a full stomach or not. You need to plan properly if there is a predicted difficult airway. Whenever there is a risk of aspiration, you must do rapid sequence induction. And consider sedation if there is a very difficult airway or a compromised airway. Sorry, I'll go back. For the pre-oxygenation, what technique we should use? You should always add nasal cannula, CPAP or NIV in high-risk cases. You must monitor end-tidal oxygen or end-tidal nitrogen, whatever facility you have for proper pre-oxygenation. We also suggested proper position for the tracheal intubation. We also suggested various induction agent, neuromuscular blocking agent, and one important point that we have suggested that omitting mask ventilation after induction of anesthesia before administering neuromuscular blocking agent, which is our practice, okay, can be avoided because it saves on a crucial time and prioritizing our primary goal over tracheal intubation. If you try to get the mask ventilation, try to see the mask ventilation, if it is not happening because patient is not relaxed, might improve after relaxation. So if you are omitting, it is still a proper practice. You should always use apneic oxygenation. We have already suggested the flows if you have a standard machine or if you have high flow nasal oxygen. We have clearly highlighted use of apneic oxygenation throughout the procedure whenever you're given relaxant. Or if you're not given relaxant, still continue oxygenation is something which is very, very important. You always confirm the tracheal tube position with end-tidal carbon dioxide. And it should not be one carbon dioxide trace. You should confirm with 6 consistent capnographic traces without any decline for proper confirmation of endotracheal tube position into the trachea. So it is very, very important that you use EtCO2, end-tidal carbon dioxide. No intubation should be done without EtCO2, and it should always be confirmed with 6 traces. For mask ventilation also, if there is a failed mask ventilation, we said straight away insert supraglottic, which might help you to improve the ventilation if it is not happening with the conventional mask. Second generation is always preferred. If you're given cricoid pressure for some reason, if there is a risk of aspiration and you use rapid sequence induction, if you are in a situation where you need to put supraglottic airway, you need to remove it because that will reduce the proper positioning of supraglottic airway and chances of ventilation goes down. There are 3 important points which we have considered in the segment of something called critical language. So we have introduced 3 terminology. One is code D, second is complete ventilation failure and emergency cricothyrotomy, which I'll discuss the reason for terminology and where and how to use it. So let us deep dive into IDA 2025 adult guideline. So this is guideline for the management of unanticipated difficult airway in adults under general anesthesia. So that's about the where it can be applied. And it starts with first thing that you've done proper pre-oxygenation and you're induced anesthesia with your primary airway management plan. Now this is different than what was in 2016, which started with intubation, but here we start with primary airway management plan. And what could be your airway management plan? It could be anything. It is not only intubation centric. Okay, you can start with putting a supraglottic airway, which is a very common scenario, or you might be doing a DNC and you just put a nasal airway, or you just put an oxygen. Okay, so anything which you have used, any type of airway management plan, or any type of anesthesia plan, this guideline is applicable. Okay, tracheal tube, supraglottic airway, face mask, nasal cannula, airway agent, alone or combination with spontaneous or controlled ventilation, this is applicable. Whatever you have planned is successful. That means you are able to maintain adequate ventilation and oxygenation. Then you continue as a plan. If waveform capnography is feasible, because in some situations like spontaneously breathing, nasal cannula, it may not be feasible. But if it is feasible, you should always check for the waveform capnography for adequate ventilation. So continuous plan. But if it is not working, your primary airway management plan, which could be inability to insert airway device or maintain adequate ventilation or oxygen saturation, is not working, that's where our guideline starts. So before going to any of this, the first thing is to look at on the left side, there are 3 vertical bars. Okay. Now, why these 3 vertical bars? This represents continuum from start to end. That means this continues throughout the guideline part. In the earlier guideline, we were mentioning it in each box. Now we have made a 3 vertical bar, continuing from start to the end. And the first thing, the most important part, is call for help. The first thing you should do, the moment you find things are not going the way you want, you should call for help. And for that, we have identified something called code D. Why code D? Because when we call for the help, the other person should know, the person who is receiving information should know what your problem is. And that is why we have called code D for the difficult airway, a clear, context-specific, time-sensitive signal. The other person knows who are you are calling, an anesthesiologist or any other person. You have an airway emergency and you are calling for airway difficulty. You must maintain adequate depth of the anesthesia throughout the procedure and continue to deliver nasal oxygen. Now, for that, there are two options we have. One is if you have a conventional anesthesia machine, you are delivering 15-liter max, which is there in most of the anesthesia machines. Or if you have a high flow nasal oxygen, and if you have started using high flow nasal oxygen, you should use high flow nasal oxygen in excess of 30 liter. And this recommendation has come after the review of literature, and it has clearly identified that apneic oxygenation during intubation can be beneficial and reduce risk of desaturation. So you should continue nasal oxygen throughout this procedure. Now, once you have done these three things, once you are unsuccessful with your primary airway management plan, which can be anything, then if it is not working, then you are there with the 3 devices. Now we call it a rescue box. You are in a rescue situation. You need to finalize and find out proper airway. So that takes us to a rescue box. And what we have done earlier in the rescue box, if you have seen our earlier guideline, you try to intubate first. If it is not working, you try to put supraglottic air. If it is not working, you do mask ventilation before proceeding to the emergency cricothyrotomy. But we have realized that it doesn't work that way. Many times at the first attempt, you realize you want to do mask ventilation, you try that, or you put supraglottic air. So what we have done is a circular algorithmic approach. So this is now a circular algorithmic approach where you can interchange between this device. There's no hierarchy that you should always use mask first or try to put tube first or a supraglottic array. This is denoted by a bidirectional arrow, so you can go in any direction. Okay, so this gives more flexibility in deciding your devices. Consider interchanging between these 3 devices. Now, in the following device, the intubation is one of the most important part. And again, as Dr. Sandeep has also described this part of guideline, video laryngoscopy is a very important tool. Either you can use primarily, but here we are in a rescue situation, and it is a very high level of recommendation. We have given it as a recommendation. The level of evidence is A, strength of recommendation is 1. So in a rescue situation, if you have a video laryngoscope, if you are proficient with video laryngoscope, then you should change over to video laryngoscope for the intubation part. This is one important thing, that if you are in a rescue situation, you have failed to do with something initially, whatever you are trying, you should try to use video laryngoscope if you have that device and if you are confident and you have experience. Now, while you are trying to do whatever you are trying to do, like trying to intubate with video laryngoscope, or if you do not have, you are trying to do direct laryngoscope, you are putting the supraglottic airway or mask ventilation, there are few important points which you should consider. Optimize your position. Ensure that patient is properly relaxed for laryngoscopy, supraglottic air, or any mask ventilation. Don't keep on doing same thing again and again. If I have done a direct laryngoscopy with one type of blade, I should try to choose a different technique, different tool, different device, or operator also. Okay. Same person should not keep on doing this again and again. And if an experienced team member is available at that point, he should take over and do the further airway management whatever you are trying to do. Now, in the lower part of this particular rescue box, these are important caveats denoted by a black text. Okay, limit device attempt, because we have known that if you keep on trying to do things again and again repeatedly multiple times, chances of complications are higher. Now, limit device attempt means each insertion should be considered as an attempt. Okay, it's not that okay, I put the laryngoscope, I have not tried with the putting the tube in. You remove it, change over with the new blade. Now you are trying to put tube in. No, each insertion of any device or laryngoscope is considered an attempt. There are another important thing, maximum 3 failed attempts. Okay, now what we have come up with each device. Okay, so with each device you can do 3 failed attempts, but that is maximum. But it does not necessary to complete. कि 3 बोला है तो 3 करना है. It's not necessary. If you feel that first attempt, no, I do not have any device and it's not going to change, you do not need to repeat. But if you're repeating, it should not be more than 3. So maximum 3 does not mean that you have to complete 3 with each device. Now, someone said that mask ventilation being a non-invasive technique, so you keep on doing in between. That is also we suggest that you keep on doing in between mask ventilation. So maximum 3 failed attempt at mask ventilation, you should stop doing that also. Okay. If you are able to successfully ventilating, fantastic. You can continue as long as you want. But if that is also not working, that's your exit point. Maximum 3 failed attempts at each, including mask ventilation. Not necessarily that you should complete that number. And this number 3 has come from the expert consensus. We did a Delphi survey because we are not getting a good evidence to support numbers. So we have gone to the expert consensus, and expert consensus across India were unanimous in saying that you should do not more than 3. Okay. Again, saturation, also oxygen saturation, there is no cutoff point, but we said that when your pulse oximetry is showing 95%, there is a lag. So we have given cutoff of 95, which is again on the basis of expert consensus. And one important point, that in some situations when your patient is critically ill with lung pathology, shock, maintaining saturation more than 95 may not be feasible. So in that situation, you may allow lower oxygen saturation when it is started with lower. But otherwise, attempt intubation only if saturation is more than 95%. Of course, this is a very important point, because in that situation, we lose track of time. We don't realize, we don't look at the saturation. Saturation is falling. We keep on trying same thing again and again. So it is important that someone should be keeping the track of time and saturation and alerting you that, okay, you've done this many attempts, this much time has passed, this much saturation is there. So someone should be doing this. That's a very important safety point. Now let us go to a situation where you are successful. You're successful means you are able to ventilate by any means, and you are able to maintain saturation more than 95%. Waveform capnography, if you are doing, if it is feasible. So if you're successful out of your rescue, if you've done an intubation, that is the best. You confirm the tracheal tube placement with waveform capnography and go ahead. But if you are successful with the primary, either supraglottic airway or mask, then consider one of the following. Okay. The best thing is to wake up the patient. If it is a planned surgery, you can always wake up. If your initial plan was intubation and now you are able to put only supraglottic airway or mask ventilate, it is best thing is to wake up the patient. You put supraglottic airway. Some of the surgeries we can either intubate or put supraglottic airway and continue. But in rescue situation, if that is not your initial plan, continue procedure only if it is considered safe, because if you have done a multiple attempt, supraglottic airway might be working at this stage, but may create airway problems later on when you stop or switch over, when you continue your anesthesia for a longer period, because airway trauma might develop. So continue only if it is safe. If you want to continue, the best thing is to intubate through supraglottic airway, but not blindly, with flexible bronchoscope. if expertise is available. And of course, in some situation, if there is a later on demand for a tracheostomy, you might go ahead and do tracheostomy. So that's your 4 options. No to blind intubation through supraglottic array. But if these 3 things have not worked, okay, your intubation, supraglottic array, and mask ventilation, what we suggest is called, complete ventilation failure. Now, this terminology is different than we have been following something which is called CICO or CVCO. Okay. Why we have not followed cannot intubate, cannot oxygenate, cannot ventilate, cannot oxygenate is because cannot oxygenate is not a very well-defined term. Okay, there is a lot of ambiguity, there is a lot of confusion. It is 95 saturation for someone, 90 for someone else, oxygen delivery for third person. So there is a lot of confusion about the cannot oxygenate term. Cannot intubate is not the only airway option. So CICO or CVCO is no longer a proper terminology. Apneic oxygenation might keep your saturation normal. So now cannot oxygenate may not work because your saturation is not falling, but you are still not able to manage that. You are not able to put any airway device. Apneic oxygen can continue, but how long? We don't know, and it is eventually going to fail. So when we suggest rescue procedure has to be done before that, before saturation fall. So this is a very good figure which we have given. There failed tracheal intubation, failure to ventilate that lung, then the oxygenation fail will occur, and then hypoxia will occur, which lead to a catastrophe. Now, CICO, CICV consider at this particular point where you fail to oxygenate and hypoxia is eventually going to occur. What we suggest that if you really want to do the rescue surgical airway, it should be done when you are failing to ventilate. That is why we have termed complete ventilation failure. CICO and CVCO is terminology which is associated with ambiguity, confusion, and can delay your decision making. So please stick to terminology which is called complete ventilation failure. Here, we have suggested that you call for additional help because now we are actually in lot of stress. Sorry. Okay, let me go back. So call for help is a very important consideration. Call for additional help. The reason is that this is a human factor consideration. New person can think better, can suggest you better, and perform the procedure very well. Okay. What the procedure which we suggest is called emergency surgical cricothyroidotomy. Okay. Now, surgical cricothyroidotomy, we have given preference to emergency surgical cricothyroidomy over needle cricothyroidomy because what we have found that in adult patient, this can be done with a very, very easy, tools. The tools which you can very clearly identify. Sorry, I think let me go back because I'm missing one important point. Okay. So emergency surgical cricothyrotomy, this has come from the expert concession and our expert concession and review of literature. And what we suggest is a emergency surgical cricothyrotomy. And what we suggest is something called step twist bougie tube technique. And this step twist bougie tube technique, which is a surgical cricothyrotomy, requires very minimum or very equipments which are easily available in all operation theater. You just need a bougie, you just need a scalpel of 10 or 11 French knife and endotracheal tube of 5.5 or 6 size endotracheal cuff tube. These are the very simple technique. If you learn, if you practice even on mannequin, it becomes much safer and easier to perform. You can do needle cricothyrotomy. There are two options which are there. One is wide bore commercial cannula, or there is a narrow bore cannula. Narrow bore cannula, which we are very much familiar and we want to put it, but you require 10 to 12 French cannula. You always require pressurized jet ventilation if you are putting narrow bore cannula. And believe me, 18 gauge cannula, which is green color cannula, which is easily available, is not a solution. So if you are putting narrow bore cannula, you need a jet ventilation or a vein train. If you have wide bore cannula, you can use it. Even if you have a surgeon who is really, really very fast in doing tracheostomy, that also is a possibility. So for emergency cricothyrotomy, there are 3 options. Actually, some of my slides are jumping. Anyway, I'll finish that part. So before that, you would consider post-procedure plan. Once you have successfully rescued your patient, you first need further airway management plan. You need to decide how you're going to plan further, treat airway edema, monitor for complications, counsel and documentation. Okay. And that documentation part, now IDA has come out with something very unique, which is called airway alert form. Okay. We have yesterday only introduced this something which is called airway alert form. So if you have found an unanticipated or anticipated whatever type of a difficult airway, you can put patient's information by going to the our website IDA in, and when you go to our website, what you will find is the information, and from that information, I'll quickly take you through it. It's the last slide. So you can go to the alert form. Okay. Now you can put patient's demography, other details, and then what were your problem, how you manage the airway, what were the complications, patient outcome. Now the important point is that when you submit, you will receive an email with the QR code, and this QR code you can share with the patient. One important problem in our airway difficulty is that patients, if they have ever encountered any airway difficulty in a previous anesthesia, we do not have any type of information. So this would be a QR code based information you will receive in your email. And if you wish to share with your anesthesia, with the patient that this was the airway difficulty, he can scan QR code and get all the information, which can be used with the next surgery, next procedure, next anesthesia. Whenever they are going to do something on that part, okay, they can definitely access this information, which is routinely most of the time lost in our field. So it is very, very important that if you have encountered difficulty and if you want to document and give this information to the patient, this would be a very, very proper method of handling the giving information to your patient. Taking back to this is our guideline document, which is published in Indian Journal of Anesthesia in November issue. You can scan this code and download entire document. Thank you very much.
Thank you very much,
I
sir.
invite you to National Airway Conference, which is also a event where we are also organizing with International Airway Management meeting, which is from 9 to 11th October in AIIMS, New Delhi. And more than 30 international and more than 150 national faculties have already confirmed their participation. Thank you so much.
Thank you very much, sir. Over to the chairperson. Hello, sir,
Yes.
you are muted.
Dr. Balavaskar, I'm part of this, so I have no questions to ask. Instead, I can take questions if anybody else wants to ask.
Yeah, that is what I was really happy since you are there.
This session is open for question and answer. Before
So
that,
there are a few.
Balavaskar sir, do you want to add something? Balavaskar sir. Okay.
If anybody
Session
has
is,
questions in the chat box, I think
yeah, they can raise their hand and
Yeah, Abhinav sir, can I say the questions in the chat box?
yeah.
2-3 questions, sir.
Yeah, so one from Dr. Sujata Zine. I think Dr. Jason already answered that. Airway collapse is also very difficult to assess in supra-obese patient. So what's your expert opinion? So you already said that pre-op VL should be done under spray and check. Any other options, sir?
So a lot of obese patients now have something called as a dynamic airway collapse, where because of that's why when they have you have obstructive sleep apnea, that is why they snore. Because the amount of soft tissue and loss of muscle inside the oral cavity in an already narrow airway, because of negative inspiratory pressure, it further collapses. Okay, so that is a very common thing that you see in obese patients who are snorers with a high stop bank score in a OSA kind of a patient. And that is why when they are asleep, they need that amount of positive pressure to splint and keep the airway open. Moreover, if you give a head-up position, the diaphragm and the abdominal panniculus that is there, that moves down, and that helps in increasing the FRC. Again, the closing capacity is much, what I mean by closing capacity is to keep the airway open. More and more volume of air is needed to keep that airway open. Okay, and often it is more than the FRC. So as a result of which the small airways tend to collapse. Now, what is the problem? When the small airways tend to collapse, you are creating more and more atelectasis and you are creating more and more shunt. So more of your lung is in zone 3 and not taking part in gas exchange because the alveoli are completely collapsed and the venous and arterial pressure is much higher. So there is in zone 3, your aim should be better oxygenation with more and more of zone 2 of maximum possible of the lung being possible in zone 2. So that is why in obese patients, some amount of PEEP, head up position, keeping the upper airway patent, keeping a high flow oxygen, pre-oxygenating well because their apnea margin is less. Okay, using apneic oxygenation with HFNC or nasal prongs and having an airway management strategy. So if your oxygenation is a problem, try and improve and optimize your oxygenation by putting a supraglottic airway device, giving a little bit of PEEP, and the first attempt should be the best attempt. Don't move on to the entire circle and have multiple attempts with the junior most anesthesiologist trying. So very often in obese patients, laryngoscopy is never a problem. You will see a CL1 view, but the optimal position, head up, ramp positioning, apneic oxygenation, adequate pre-oxygenation, getting the tragus in line with the anterior clavicular, anterior humerus, the line in line with the humerus and suprasternal notch. All these are the important things that you need to take care of. So when you do all of these things, you make a physiologically difficult airway easier to manage.
Yeah, so I think what madam wants to ask is, like, how do we assess pre-operatively?
So
Means
again, there
it's
are
going to
dynamic
be
sleep studies which are often done. You can always get them a polysomnography done and look at the AHI score. All of these are the other things that you can assess. And you can ask the partner whether they snore a lot. So in these cases, it is better to preempt. So dynamic airway collapse can happen in anyone. So even it's not only necessary that it is there in obese. Obstructive sleep apnea is a disease of even other lean patients as well. So you can't predict a dynamic airway collapse. You can maybe topicalize the airway and look at a endoscopic evaluation and you can see how much the airway is collapsing. That is in a upper airway. In a lower airway with a long-standing thyroid where you have tracheomalacia, you can probably put a fiber optic scope through the endotracheal tube. So that is a part in the at-risk extubation guidelines that you can, when you are awakening the patient, you can gradually withdraw the endotracheal tube over the fiber optic scope and you can see the distal airway collapse. If there is tracheomalacia, if there is distal airway collapse, keep the endotracheal tube in situ like a splint, okay, for a couple of hours till they are able to completely manage, or you can extubate them over a high frequency nasal cannula or a PEEP or BiPAP machine, or if they are using a CPAP BiPAP machine at home to extubate over that. Okay, so these dynamic airway collapses, these are the secrets how you deal with lower airway versus upper airway.
So madam had Sujata madam, are you there? So madam
Yes,
had
ma'am,
one
I'm
more
there.
question.
Yeah.
Yeah. So we
Thank
want
you.
to see our
Explained by sir.
dynamic
Yeah, yeah,
madam.
yes.
So madam has one more question, whether use of flexi tip buji along with VLS. So we also use it frequently. What is your take on that? Bala Bhaskar sir, do you want to say something? Using a flexitip bougie along with VLS, video laryngoscope. So should it be routinely used or only in difficult? Because I think nowadays I routinely use it.
No, I don't get the.
So whether we should be routinely using flexitip bougie along with the video laryngoscope for intubation.
Sir, with the video laryngoscope, as sir has rightly mentioned about the channel, non-channeled, the source of light where it is situated, the angle, that all these things comes in into consideration when we are using VLS, right? So many a times the bougie gets stuck to the anterior part or to the right part or to the lateral wall of the trachea. So using a video laryngoscope with a flexitip bougie, does it enhances the first attempt intubation? Secondly, again, there is some technical, more and more of the technicality, right? We are already using one video laryngoscope as a newer gadget, and another thing of the flexitip bougie.
Understood, madam.
No,
the second factor would become prominent, I think, because it adds to technical confusion, definitely. So we are used to, for example, if I am used to using the video laryngoscope, I have become perfect also, there is no issue. I got grip over the whole system and I can use the additional illumination there along with the flexi tip and as I go forward. Okay, that.
So, sir, maybe then madam is talking about the combined technique where, we have a video laryngoscope, we already put it inside and then we give it to our technician to hold it. And then we are using a maybe ambuscope bougie or any other flexible bronchoscope to navigate.
No, understood. So that can be a possibility. Only thing is it adds to a little bit of technical confusion, coordination between, for example, me as a primary person who is doing the laryngoscopy and the assistant who is there. Both of us, for example, looking at the monitor, it would definitely help in guiding it further. Okay, but when we have the CL improve, all of us agree that Cormac line grading would definitely improve with video laryngoscopy. There is actually a better facilitated passage of the endotracheal tube with this additional device. I don't think there are that many evidences as such. Right, Doctor?
Okay,
Yes,
sir.
Yeah. So with the video laryngoscope, a couple of important things here. When you are using a hyperangulated blade, it is always better to pre-form the endotracheal tube with a stillet to match the curvature of the hyperangulated blade.
Yes.
Again, blind advancement of bougie is not recommended. Even IDA guidelines say that. So you can use an angulated tip bougie where you can adjust the angulation along with it, provided you are passing it under vision. So again, like Dr. Kadam sir also alluded in his talk, that you can use a WAFI kind of a technique where you have a video laryngoscope and you are using the bronchoscope as a video stillet, okay, and you are passing it through the vocal cords. When you are doing that, the newer versions of video laryngoscopes, which includes the Karlstorz as well as the Ambu, have something called as a split screen. So in the same screen, you can connect a video laryngoscope and you can connect a fiber optic scope. So, and the screen is split into two. So on one side, you will get the video laryngoscopic view, and on the same screen, on the side, you will get a flexible video endoscopic in a fiber optic view. So you can maneuver looking at the same screen and you don't need to switch the screens between two screens, or you don't need two separate screens. Okay, so in this split screen, that is possible. And when you're using this angulated tip bougie, yes, definitely if you're not causing trauma and if you're used to using it, there is no harm in using angulated tip bougie where you can change the angulation so that you are entering the glottis under vision.
Maya madam had asked.
So,
Sorry, yeah.
So
Sujata madam?
basically, you should try to practice.
Yeah.
On a normal airway. Try to
that's a
practice
matter
in a
of
normal airway.
practice.
Don't attempt this.
Yeah.
Using the
Even but using a hyperangulated blade, I am very much used to use a bougie, not the stillet. So it is just a matter of practice probably. So the bougie goes very smoothly with the hyperangulated blade as well. So just to say not to use a bougie with a hyperangulated blades, I have a little bit of conflict on this. Just
most of the video laryngoscopes which are a hyperangulated blade, no, they have their own bougie or they have their own stillet to match the curvature of the hyperangulated blade. So if you see glide scope and all, if the glide right stillet which is matching the curvature of the hyperangulated blade. So again, that is depends on you. If you don't want to use the stillet, but Remember one thing, that you will not be successful with an endotracheal intubation if you are using a hyperangulated blade and you are not using either a bougie or a stillet. Your tube will always go posteriorly because the curvature of the laryngoscope blade is such that you will be able to get a fantastic view, but your tip will always go posteriorly of the endotracheal tube. So whether bougie, stillet, preformed curvature of endotracheal tube, whatever you use, you have to make sure that the curvature of that matches the curvature of the hyperangulated blade. That is important.
And any
Thank you so much,
preference
sir.
over channel and non-channel VL scope, sir?
Yeah.
Get trained in all of them. One channeled, one hyperangulated, and one regular Macintosh. So like Dr. Amit Shah said, that use it in a normal airway, have your airway spectrum and armamentarium widened. Why would you limit yourself only to one? So you use one of each. You use a channeled, you use a hyperangulated, and you use a Macintosh. And you use also in fiber optics. So you have a variety of equipment that, and all the learning curves and all the gadgets are completely different from each other. So it's not like one gadget you are comfortable with that will help you bail you out in all the kind of scenarios. In some case, you will need certain situation, you will need a certain type of a channel blade. Some situation, you will need a hyperangulated blade. Some situation, you may need to use a Waffy technique. So again, getting trained in more and more in a normal airway is always advantageous because you have the expertise of doing. So actually, when we train students, we make them even. Somebody tells you that I am in a remote location, I don't have a flexible video endoscope. So that is not an argument in today's era because the flexible video endoscopes cost 30,000-40,000 rupees. So you can invest in buying your own. Okay, it is always going to be beneficial. But if it malfunctions, you still have to be trained in retrograde intubation or some other awake technique, awake video laryngoscopy. If your awake video laryngoscope, video endoscope or flexible scope fails, you do awake video laryngoscopy. So if you know how to topicalize the airway well, if not one technique, your plan B, plan C is always there to back you up and save you.
Yes, sir, I
Okay.
agree.
Yes,
We have Dr. Maya Madam had raised hand. Maya Madam, are you there? Maya Madam, I think had joined from US.
Wow.
Yes, and Maya
Yes,
Madam's
yes.
question.
Yeah, I'm there,
Yes,
Shilpa. Yes.
yes. And I think
Excellent
you had put a
presentation by.
question about pediatric cases and VL scope. Was that your question?
Yes. Use of video laryngoscope in routine cases in pediatric patients. Does it require different skill sets or because I'm doing it regularly, but sometimes I find some difficulty and I have to use the stilet. So I just wanted updates from our speakers or chairpersons.
So I do a lot of pediatric work, and fortunately, I've been privileged enough to be the lead author for the pediatric airway guidelines. So when we did a literature search in neonates, video laryngoscope it definitely translates into better video laryngoscopic view and success of intubation. There is a meta-analysis on that. So there is no doubt that in neonates, the correct size of video laryngoscope is helpful in viewing the glottis and securing the airway. In children, although it is recommended to, it is found that the video laryngoscope view improves significantly, but it need not translate into improved success. So whether you are using conventional laryngoscopy or video laryngoscopy, the view will be much better with the video laryngoscope, but no studies have found reduction in the time to intubation or improved first pass success rate with a video laryngoscope as compared to a conventional direct laryngoscopy. But again, you have to realize that in children also, where there are syndromic children, most of them will have an anticipated difficult airway, but a awake fiber optic is not possible. Awake video laryngoscopy is not possible. So you put a nasal trumpet, you take them under with inhalational agent. You have pre-secured an IV access under EMLA cream. But video laryngoscope we use very often in pediatrics with the kind of cases that we do. And it is definitely advantageous and is very helpful. So again, important thing is when you are using a video laryngoscope, right size bougie, right sized endotracheal tube, right size video laryngoscope blade, specific to that pediatric population and pediatric age and weight is very important. So there is a Mac 0 blade that CMAC has. There is a Miller blade that CMAC has, Karl Storz. There are pediatric blades available with ambuscope as well. There are pediatric channeled blades. AirTrack has come out with pediatrics. So I'm not recommending a particular company, but whichever company you are using, you make sure that it is age and weight appropriate and you are using the right equipment for the right patient. So it is definitely helpful. There is no doubt about that in pediatrics also.
Okay.
Yes,
So
yes.
I
Thank you,
had
sir.
one.
Excellent. That's really excellent inputs. Thank you so much.
Thank you so
So
much,
You
at
madam,
need
one
to
for
use
joining.
the
yeah.
stelate in every pediatric patient also.
So if you are
Yeah,
using
yeah, most of the
triangulated
times. Or otherwise you have to manipulate the curvature of the tube
Tip of
correct,
by
tube
just doing
curvature.
some maneuvers.
correct.
Sometimes, sir, oral intubation or laryngoscopy and intubation is easy, but sometimes we get difficulty in during nasal intubation. So, how should we deal with this?
So in pediatrics
No,
and
no,
adults,
in
yeah.
adult.
So it is an excellent training tool when you have trainees in your institute, or if there is somebody junior who's intubating. The advantage and beauty of video laryngoscopy is the person who is more experienced can actually look at the screen and guide you when you are doing that. Now, when you are doing nasal intubation, Dr. Kadam sir had brilliantly pointed out that you can use the cuff inflation technique. We have done a study on that. Okay. And we've not yet published it. It's in the process of analysis and things like that. So where we've taken multiple patients and in head and neck cancer patients, and we have used the cuff inflation technique. So you have a video laryngoscope, either a regular blade or a hyperangulated blade. So whenever we are doing a nasotracheal intubation, we make sure that we tell the trainee that first do a laryngoscopy, okay, and look at what is the glottic view. Because when you try and put a tube through the nostril, very often if there is bleeding, it is going to make matters difficult in an already difficult airway.
Yeah.
So when you have blood is an enemy of the video laryngoscopy technique or a fiber optic, right? So you don't want that. So you use the video laryngoscope and you look at the glottic view. You lubricate the nostril well or put otrivin drops, use a nasopharyngeal airway to dilate the turbinate and the nostril passage. You lubricate it well. Then you pass the softened endotracheal tube. You can warm it with steam, or you can just lubricate it well and pass it along the nasal passage. And then once it crosses the soft palate and you can see the tube in the oropharynx on the video laryngoscope screen, you can inflate it with 10, 15, 20 ml of air so that the tip gets directed anteriorly. The tip enters the glottis and then deflate it and rotate the tube and enter the glottis. So I think Dr. Kadam sir also pointed it out in his talk. And that is a really good technique for improving the success of nasotracheal intubation. Another thing that you can use these Parker Flex tubes, which don't have that arytenoid holdup. So very often you will find that the tip of the endotracheal tube will get held up at the arytenoids and it can cause fracture of the arytenoid cartilage. So you need to rotate the tube so that you enter the glottis so that it does not get caught up at the arytenoids. And at the same time, if you use these Parker Flex tubes, they have a special tip, which is like a parrot beak tip, which helps. And even I think Tuoren has come out with this soft tip tube. So some of you must have used the LMA
Yes.
fast track, the ILMA tube. So the ILMA tube has a tip which is a siliconized tip or a soft tip, which helps in preventing this arytenoid holdup and arytenoid damage. And it just slides over the arytenoid into the glottis. So those tubes and all these techniques are very helpful in improving the success with nasotracheal intubation.
That means instead of holding it with Maggie's forceps,
Magill's, what the problem we face is if the trainee holds the cuff with the Magill's forceps, the cuff gets damaged and the cuff gets
yeah,
ruptured. So you've put the tube and
And
then it's very often time to change it again.
yeah.
And
Yeah.
also with the hyperangulated blade, the McGill tip is not visible
Correct.
because it has one angle.
Correct.
So there is a specific McGill forceps or modified McGill or a Bodecker forceps,
Bodecker forceps.
which is available, which is a second angle. So you need to use with hyperangulated blade that sort of what you call forceps to visualize the tip and guide your tip into the larynx. So if you do not have that, this cuff inflation technique, which I feel in adult patient should be inflated by 20 ml to get the tip reasonably up to guide it towards the laryngeal opening.
Sir,
What?
may I end it?
Yeah. Yes.
Yes, sir. As you rightly said, in hyperangulated blade, we cannot see the tip of this Magill's forceps. But if we look at the oral cavity, inside the oral cavity, rather than looking at the screen, and we just hold the maggots just beyond the cuff and then slide the tube into the glottic opening, it goes very well without damaging the cuff.
I know. No, it
There
is
is more
possible
than
to
one
do
way of
with.
doing it. There is no doubt about that. But this is just the additional thing that you can use. So
See,
I guess
if you are really
possibly
experienced about it, you can always do it. So
For
sorry, Joseph, sorry.
may I say something? For all my nasal
Yeah.
intubations, I put a J-tip flexible bougie from the nose, and I guide with Maggles the bougie if required, and then over that I put the tube. I don't know whether it's right or wrong, but then it goes
Sorry,
very
I
smoothly.
lost the voice in
I don't
between,
know.
sir.
I have to hold the cuff. And so someone is asking, are the experts making nasal bougie available for guided intubation?
So there are certain soft tip bougies that have been marketed. Again, with the FROA that is being used, that is very stiff and that can cause a lot of turbinate injury and bleeding. So ideally, if you are using a bougie, you should pass a nasopharyngeal airway and pass the bougie through the nasopharyngeal airway rather than passing the bougie directly through. Sometimes, very often, you can get stuck because if it starts bleeding, then it will be a disaster. So if you want to protect the nasal delicate mucosa, prevent epistaxis, bleeding, turbinate injury, either use a nasopharyngeal airway or use the soft tip bougie, and that I think will be beneficial as far as.
Yeah,
Even a
Amit
false
Shah,
passage
sir.
is possible.
I think
Even a
Shilpa
false
has,
passage is possible if you are using
Yeah.
bougie.
Yeah.
now
Last question.
I know there will be so many questions and queries for this session.
Sir,
But,
माझ्याकडनं एक last question.
okay, but
I
we
wanted to ask Dr.
we
Amit Shah,
will try
sir.
to stop.
Sir, why
some minutes.
3 attempts at laryngeal mass airway? If you are facing a difficult airway and whatever Supreme, iGel, Prosil, whatever LMA you have put, and if you're not able to ventilate that LMA, we were taught when LMAs came, we were taught that if you're not able to ventilate through LMA, just remove it, do mass ventilation. So why? And with second,
Yeah, so
suppose
changing
I
the
try some second LMA.
size. So changing the size, or when you put a LMA, if there's a leak, you feel you're not able to ventilate, you might want to put another LMA, a bigger size. Okay, that's what we do, right? So that's what we do. Now there's a evidence which suggests that changing the type of supraglottic airway might help you. In fact, there's an evidence which suggests that if you change over from Supreme, what you call Prosil LMA to a newer LMS, okay. So changing the type of LMA also can help you. Also, if your initial planning was a supraglottic where you have put and you realize there is a leak or you're not able to ventilate, you change over to another one, you can still continue surgery. That is why the expert consensus allowed us to go ahead with the 3 attempt. Okay. You can definitely decide to abandon after first attempt also. Okay.
Because sometimes there are
It's
secretions,
not
blood.
so it's not necessary to complete 3. Okay. But if you keep on trying, don't go more than 3. Okay. Most of us will probably decide in first or second attempt itself that, okay, one is working, one is not working. You have put a bigger size or a different type, and that's all. But don't try more than 3. So that's maximum 3. We don't say that you always try 3. Okay. That's maximum 3. Routinely, why this has come up? Because changing from one size to a bigger size is something which we do routinely, and there are evidence which suggests that changing a type of device might help you. Okay, so that was the rationale behind asking expert whether we should go with 2 or 3, and then expert consensus was for the 3, so we put 3. But again, very clearly, it is maximum 3. You don't need to complete 3 numbers.
Thank you, sir. And
Thank
Shobha
you.
madam had asked whether fiber optic bronchoscopic intubation can't we do orally. For that, I think we require the Burman airway. We can do it.
Okay.
Bala Bhaskar sir, want to say
We
something?
can do very, very well. I guess the endoscopy mask per se, I mean, airway per se will be given. For example, Starch gives a small airway. It's like a Burman airway where we can still pass the endoscope through for the bronchoscopy purposes. Only thing is, because of the angulation, we should be trained enough to maneuver the scope inside. Otherwise, it's not difficult if you have a good practice. There is no harm.
Okay.
possible.
Dr.
One
Deshpande,
more
sir, do you want
jugaad
to ask?
here. Yeah.
Especially awake patients, if you are doing, only thing is oral anesthesia. The oral cavity must be adequately anesthetic. The oropharynx and definitely the laryngopharynx part has to be nicely anesthetized. Because oropharynx, no anesthesia is not that much required when you speak about the nasotracheal approach. Okay, so this must be ensured. Technically, slightly difficult, but it is possible, especially in an awake patient.
Okay, sir.
Yeah.
Yeah, over to you, Sheetal madam. Avinash, sir.
Over to Sital. We will stop here. It's already 9:15. So I request you to present a vote of thanks.
So it's my honor to propose the customary vote of thanks. My sincere gratitude towards both our chairperson, Dr. Balabhaskar sir and Dr. Jensen, for sharing their valuable experience and valuable inputs on the respective topics. Then my sincere thanks to all the faculties, Dr. Amit Shah sir, Dr. Sandeep Kadam sir, and Dr. Saurabh Burde, for giving the very crispy and lucid talk and sharing the practical tips which can be incorporated in our day-to-day practical practices. And my special thanks to today's MMC observer, Dr. Rathod from Yavatmal. Special thanks for the President Yavatmal, ISA Yavatmal and IMA Yavatmal and Secretary, Dr. Imlata Badke Madam and Dr. Archana Pargut for getting MMC award. So in 6 months, we have given 6 MMC credit awards for the webinar, one per webinar in 6 months. So thanks to all presidents, secretaries of various branches, and thank all delegates for tremendous response as always. Today, almost 187 delegates had attended the webinar. Thank you very much. Welcome.
Bye.
Okay, thank you.
Thank
Thank
you.
you very
Thank you
much.
all.
Thank you. Thank you all.
Thank you.
Thank you, sir. Thank you so much.
Thank you.
Thank you, everyone.
Thank
It was
you for